Welcome, everyone, to the Friends of NPACE podcast. I am Terri Schmitt, the Executive Director at NPACE, and I'm also a practicing family nurse practitioner. And I am so excited to introduce today's guest and the topic we're going to talk about. It might be a little tough at times, but this is definitely something we believe at NPACE is an important topic to cover. I am excited to introduce Dr. Rhone D'Errico. He is a doctor of nursing practice, and he has certifications as a family, a psychiatric mental health, and emergency nurse practitioner. And you began your RN career in the neonatal ICU, which so did I. We'll talk about that another time. But I love how that pulled you right in. And then you were in mental health, primary care, college health, and the emergency department. You are a very talented speaker, and you're going to actually speak for us at the upcoming conference in Las Vegas about the topic that we're going to talk about today. And you're also a teacher. You've taught in FNP, psychiatric mental health. You're currently a full professor at Rasmussen University, and you're a primary faculty and track lead for the PMHNP program, correct?
Yes.
And you're practicing currently via telepsychiatry, which is a big deal because it's access. Tell me a little bit about that.
Yeah, absolutely. Well, thank you for having me, Terri. I'm really excited. And I'm excited to get to talk to you and talk to your audience today. This is a big deal for me. This is a lot of fun. So thank you for having me. Yeah. So in terms of my clinical practice, I practice 100% via telepsychiatry, and I work at a couple of different sites. You know, my day job is as professor in the PMHNP program at Rasmussen University, but I do keep a pretty solid clinical workload going as well, which I do very purposely because I think that makes for better nurse practitioner faculty, honestly, when I'm able to kind of talk to my students about the practices I'm having on a day-to-day basis. So my primary clinical site at this time is a 120 plus bed rural intensive inpatient and residential drug treatment program. So this is a site that's kind of out in the boonies. They have a very, very high need population of dual diagnosis of substance use disorder and a wide variety of mental health and psychiatric illness concerns, including some pretty severe pathology. I've gotten some pretty severe psychiatric pathology coming across my virtual desk working there, but I just love the site. I love the people. I've been there a few years, and I just feel like I'm able to make a really good difference because they are really doing a lot for their community and actually for their entire state in treating dual diagnosis and substance use disorder. So I was originally the sole provider for the entire practice, which is huge, including a women's services department, a specialty program for pregnant and parenting women, and then a separate men's 28-day drug treatment center. They eventually actually hired an on-site psych NP for the men's treatment center, and I actually had the great pleasure of being able to kind of orient and mentor her because she was a new grad, and now she's doing awesome. So she runs that site, and I've been overseeing the women's services since then.
I love how excited you got about mentoring a brand new NP. Yeah. Oh, well, that's a whole nother topic too. See, I can get so tangential with this. Oh, yes. Thank you so much for the work you do. You and I come from similar value systems. I do a telehealth practice because it makes me better at this job that I do every day. And it's about access to care and meeting people where they are. Most of my population is adult Medicaid or uninsured or underinsured or rural. And so it's interesting how telehealth has opened this access gate for people.
Absolutely. Yeah. I took my first online college course in 1999. It was one of the I think it was the very first online course offered at the University of Nevada, Las Vegas. I was a psychology major at that point. My first BA is in psychology, and it was a statistics course, as I recall. And I remember emailing the professor and saying, you know, this is amazing. This is going to be the future of education. I think this is huge. And he actually even kind of wrote me back saying, yeah, you know, it's a thing we do. Fast forward to today, where I teach in a fully online program. I provide telepsychiatry, so I take care of my patients via online services. I'm currently engaged in a therapy training program that the didactics are online. I've gotten 2 to 3 of my degrees online, so it really has just become the way of our world. And I think, like you said, we can do a lot of good using this modality. I love in-person work, but we can make a lot out of this modality, and we can do a lot of good.
I completely agree. I love how passionately you said that too. And technology can be our friend in all of these things. We are going to talk about the subject of suicide, risk assessment, prevention, and that's your area of expertise, and you're actually going to speak on that in Las Vegas. But before we dive into that really tough, deep subject, one thing I'm doing in season 2 of our podcast is asking all of the nurses, how did you find your way into nursing? If you started as a psych major.
Yes. So I started working full-time around the age of 15 or 16 due to necessity. And I was born and raised here in Las Vegas, Nevada. So I started working in the restaurant field. So I started as a busboy around 15 or 16, talked my way into a promotion as a waiter at around 16, I think, because I went to my boss and said, hey, you know, I have family needs and I need to make more. And he said, well, you're pretty young, but I'll give you a try. And I did that. So I worked in the restaurant industry pretty much exclusively for about 10 years. During that period of time, I was always going to college, but I didn't know what I wanted to do. So I'm one of those that took 10 years to get my first bachelor's degree. It reminds me of that line from that Chris Farley movie. I think it was Tommy Boy, where they say, you know, he says, lots of people go to college for 10 years. And David Spade says, yeah, they're called doctors. Well, that was me. It took me 10 years to get my first degree, and it was a BA in psychology. I got to a point where I had so many credits because I kept changing majors. Then I said, well, what can I get in a relatively short period of time? If I did some 300 and 400 level courses in psychology, I can get my psychology degree. Well, it was great. I loved it. I actually did some undergraduate research in an experimental psychology lab. But here I am. I've gotten my degree, and I went from one day being a waiter to being a waiter with a bachelor's degree in psychology. And that didn't get me very far. So I looked around and I wanted a profession. I wanted something that I felt I could actually put my skills and knowledge and ability to use to be of benefit to more than just myself. And I sort of landed on nursing. And that's really the whole story. There wasn't any other connection to it. I had zero healthcare experience. I had some family that had some pretty severe health issues in general. So I had encounters with the health system through that. But personally, I never worked in healthcare or really had any family members or knew anybody that worked in healthcare. But I was looking at nursing and I said, you know, this seems to fit my bill. I was looking at graduate work in psychology. And at that point, which seems kind of foolish at this point, but at that point, I was like, gosh, it's going to take me I think it was 6 years to get a doctorate in psychology because they went straight through. There was no master's. And I said, gosh, that's just too long. That's going to take me forever. I mean, this is like, what, 20 years ago at this point. So, of course, in hindsight, it wasn't. But I said, I want something that I can get working a little quicker so I can actually start putting my skills to use. And I looked at the bachelor's of nursing program at UNLV. I'd got my BA at UNLV. I said, well, I already have all these credits. I just had to take a few more specific courses. And that's how I did it. I got into nursing. I entered the Bachelor of Nursing practice, Bachelor of Science of Nursing in UNLV, and graduated in 2007 with my BSN.
Wow. We got so lucky in that as a profession. I love that story. Practicality is how a lot of people end up here, interestingly enough. And I love that people bring their history with them, right? Your background in psych mental health has definitely informed how you're practicing now. So I would guess that's how you got into the mental health side of nursing. Tell me a little bit about that, and then how you got interested in suicide.
Well, that's pretty circuitous as well. But I will say, and just to your original point, going that way into nursing is the single best career choice, a professional career, personal life choice I've ever made, really, in terms of career. I'd say marrying my wife, Maria, is definitely my number one best life choice overall. And we're actually going to be celebrating our wedding anniversary right about the time I'm speaking for NPACE in February. So yeah, just a
Bring her over.
a little bit before, a couple of days before. So, but in terms of my professional decisions, becoming a nurse really was the best. So it's kind of the similar type of vibe of went from being a waiter to being a waiter with a bachelor's degree. Well, I went from being, I had a nursing degree and I went right into the neonatal ICU. Loved it, worked there for several years, worked my way up, got on the resus team. So I was attending the high risk deliveries, resuscitating high risk infants, seeing the sickest of the sick little babies. But I kind of felt I hit a little bit of a plateau there. I didn't want to become a neonatal nurse practitioner. I wanted to do something a little different. I get restless. I get bored easily. as my life history can probably demonstrate. So I didn't want to be a neo-NP. So I was like, well, I'll go be family. And kind of like jumping into nursing, I had no idea what was involved in being a family nurse practitioner. I just kind of went for it. Now, I advise students currently, I've mentored a lot of nurses wanting to go into being a nurse practitioner, a lot of MSN level nurses or even BSN level nurses wanting to know more about the DNP. So I've mentored a lot, and I never actually recommend this path I took of just randomly picking things, but it kind of worked for me. So I don't want to be a hypocrite about it. So I went ahead and I attended the FNP program, graduated with that, and I was still doing per diem shifts in the NICU, and I kind of didn't know what else I wanted to do. And someone told me, and anybody that has any emergency department experience will laugh hilariously at this, but I had never worked in the emergency department, no experience as an emergency nurse, hadn't really spent time in ERs. And someone I knew said, hey, I know this group, they're hiring FNPs, they have you work in the ER. It's super easy. So this is the part where everybody's going to laugh. It's super easy. You just kind of sit in triage, you see patients, you kind of put in orders on them, but it's no problem. You don't need ER experience. I was like, yeah, that sounds kind of cool. So I interviewed with the practice owner. So it was a physician group that staffed the local ERs. It was a privately owned provider group. So they had physicians, NPs, and PAs. Mm-hmm. And they said, oh, I think you'll be great. So I got into that job. Of course, it was not super easy. Probably the most challenging professional experience I've ever had in my life. Very, very challenging. Very, very challenging. In actually the ER where I was born, or the hospital where I was born, I was working in that ER, strangely enough, and just seeing the sick of the sick. Very, very extremely busy, high acuity, level 2 trauma center, inner city, and it was a steep learning curve. And so I worked in the ER for several years, and I will shorten my full CV, but I worked up the leadership ranks there. I worked up clinical leadership. I ended up in a healthcare executive leadership group with that group that got bought out by a national staffing agency. So I worked up my way up to a vice president of operations over multiple contracts in the Western US. And then I got an opportunity to teach as an adjunct. And I said, oh, I've never taught before, but this sounds interesting. So I worked as an adjunct for a bit, and that in an NP program. And that led to me eventually leaving my executive position for a full-time professor position. And I've been a professor in teaching ever since. And then clinically, when the pandemic hit, I was working per diem in the ER because my full-time job was as a teacher. And when the pandemic hit, all the per diem hours got cut. Those of us that were in the ER realized our volumes actually went way down because all of the low acuity patients stopped coming to the ER because everybody was scared of the pandemic. So it was much less volume, but much higher acuity. But those of us that were per diems weren't getting hours anymore, which is reasonable, right? I wanted the full-timers to get their hours. So I dusted off, and I go through the story. I kind of skipped the part where I went ahead and did a Psych NP postgraduate fellowship during that period, a post certificate. Wow. And so I had this Psych NP that I hadn't used much. And so I started working as a psychiatric NP with a couple of local clinics. And after several years of that, that's where I am today, working as a Psych NP, working as a full-time professor. So it is a very, very circuitous route I've taken over the years. But that's kind of it in a nutshell.
I love that. Our paths were very similar in many ways and all over the place.
And here we are.
I know. The universe lands us where we need to be.
Absolutely.
So where did you come into the topic of suicide first? Was it in your ER experiences? And did that inform then your mental health practice? Talk to me a little bit about why it matters to you.
Yeah, the psych I dealt with in the ER was, of course, a lot of suicidal ideation, patients being placed on legal holds, patients coming in needing medication refills. And during this time that I got my Psych NP, my postgraduate certificate, I was still working in the ER. But one thing I noticed is that my comfort level with these patients just changed radically, which you can imagine. So I was still working as a nurse practitioner in the ER. But as patients with psychiatric concerns would come in, suicidal ideation, things like this, my comfort level really just changed because of my education and my clinical experiences as a student. And I realized that, a lot of my fellow providers, much like I had been, were very intimidated by these patients. It's frightening, it's overwhelming, it's confusing. It's what do I do? I talk about this in my talk that I'll be giving in February, where we all do suicide training as healthcare professionals. We do a ton of suicide assessment, prevention, the topics ostensibly that I'm going to speak on, but we do a bunch of it. We know it inside and out. There's no mystery. I could pull a BSN student aside and say, tell me about suicide assessment, and they would probably give me a pretty good answer. What it comes down to is when you're sitting down and you have that patient in front of you and they make a statement that they're thinking about harming themselves or taking their own life, and you as a provider are going, oh gosh, all my training just went out the window. What do I do? What do I say right now? I know the assessments, I know all the statistics, I know the epidemiology, but what do I actually say to this fellow human being in front of me? And that, as I got psychiatric training, I realized was really a missing piece, that those that are not in psychiatry, and even some of those that do work in mental health, that can be lacking. What is that actual actionable piece to it? So this was developing as an interest of mine, along with other kind of what we call integrated care now, bringing these mental health topics into a primary care or other non-psychiatric setting. I'm very passionate about, because I think it's all one. We're all one human being. We're not divided. So we're artificially divided in terms of our practice settings. So that became an interest of mine. I had to develop, when I went from being an adjunct to my very first full-time professor position, this was an assistant professorship at the Touro University, Nevada Family Nurse Practitioner Program, you do a faculty presentation and you have to think of a topic to present. And this is one of my very first presenting opportunities other than small groups. And I said, what do I want to talk about? What really matters to me? And I said, I'm teaching the role at that point, because I'm dual certified at that point, I could teach psych to family nurse practitioner students. And that was one of the great innovations of that FNP program. And I said, well, okay, what's a topic that I want my FNP students to know and even my colleagues to know? And it was this topic. It was suicide assessment prevention training, with an eye towards what do you really do with that suffering human being in front of you to do your very best to keep folks safe, to help people heal and be whole. And that's how it started. So I developed the talk at that point, and it's just evolved over the last several years from there.
I love that. The audience knows, for any of you watching, any of that, I take copious notes because I always learn when I get to talk to people. So I love what you said about mental health is really not divided from physical health. And so much of that overlaps. And we know that, right? The rates of depression among, say, people who have diabetes is 2 times the rate of the general population.
Absolutely.
I love the human compassion piece about, the person in front of you and that they're a fellow human being. And so how, although it's clinical, it's also human, for lack of a better term. What do primary care, ER, urgent care providers need to know first? We know how to identify maybe, or do people sometimes not reveal what's going on? How's the best way to kind of get to, are you at risk? And then what do we do next?
Well, I think there's a lot of formal answers to that I will give. I will say my very first answer, now that we're in the circle of trust, we're talking to our fellow NPs, PAs, physicians, everybody in healthcare, RNs. My first answer is trust your gut.
Okay.
If your gut says to you, something's going on with this person in front of me, that's the first thing to listen to. And this is something sometimes we don't always just come out and say, but when we're doing things like training for sex trafficking, right? When we're training for domestic abuse, suicidality, any of these things, trust your gut. If you have graduated a BSN program, you have had interpersonal clinical experiences that 99% of the human population has not. So if you're a day one BSN new grad, you have had more of these experiences than most people. You're starting to develop that gestalt, that instinct. And if you've been practicing in healthcare for any amount of time, you definitely have it. And I think honestly, sometimes we kind of suppress that a little bit because we're really busy, because we don't necessarily want to open up a can of worms. We don't want to offend them. Their spouse or their friends or their loved ones are right there with them. So we have all these competing things going on. But at that base level, I would just say trust your gut if you think something's going on. The second biggest base fundamental, and I like fundamental, I like getting just to the very core of things. The next core thing is that it is well proven in experience as well as in the research, you will not induce suicide or self-harm by asking about it. You will not cause. Now, we have a whole separate concept of suicide contagion, where when there are suicides in the media, especially of prominent figures, or there's television shows, we do see increases in rates of suicide attempts and completed suicides. That's a real thing, but that is not the same thing as a person asking another person. And we're talking from the healthcare provider standpoint, but this goes for your friends and family as well. Just asking, hey, what's going on? What are you feeling? We always start there, right? But even just saying, are you thinking about harming yourself? Have you thought about this? Have you thought about how you would do it? You're not going to cause someone to say, well, I wasn't going to, but now you asked me about it. Now it's in my head. We kind of worry about putting it in people's head. The research is crystal clear. You're not going to induce anybody to harm themselves just by asking. It's the opposite. Just for a certain percentage, and there will always be that percentage that you are never going to change their mind regardless, right? And that's kind of an important but separate discussion. But for a large part, when we do these postmortems on suicide survivors, so meaning the people that may have attempted suicide but did not die by suicide, they survived the attempt, they will often say, if someone had just talked to me, I don't think I would have done this. So we see that over and over again. And we see people say that just because someone spoke to me, I did not attempt. So just asking and being forthright, and the other great skill that I think I've learned from psychiatry, from my training as a psych NP, again, it's these basics. It's not the fancy psychopharmacology. It's not the neurobiology. It's the basics. Normalization is a huge thing. If I can teach primary care and non-psychiatric providers one thing, it's to normalize all these things, asking about suicide, asking about trauma, asking about non-lethal self-harm, just asking about substance use. I mean, obviously, that's something I work in. Normalizing these things. I'm not going to be shocked. I'm not going to be judging you. I'm not going to hate you. I just want to talk about this. And that itself can be a hugely healing process. So I would say trust your gut and just ask are my two. If you just remember two things about suicide prevention as a healthcare provider, trust your gut and just ask. And then the natural question is, okay, I asked, now what do I do? That's kind of more of what I talk about. That's a bit of the bread and butter, because you've opened up a whole thing at that point, right? And it's easy for me to say, just ask. And that's what all the education tells us, just ask. And then you get to the point, well, okay, I asked, they said yes. Now what do I do? And that's, that's the second part of it. But the beginning is just to ask.
All right. Well, I actually want to divert the conversation then and pull from your experience in the ER and now at an inpatient facility and doing the telehealth you're doing. Do you find that when patients speak up and say, I have thought about this, are the primary care sending them on to the ER? And then I guess I'm trying to decipher as a primary care, are they heard? Are they seen? The ERs are overrun with lots of stuff. Like, is that an effective way? I want to keep someone safe.
Yeah.
Does it translate? And is that a safe place for people, or are people more afraid of disclosing? So I lived in Missouri for a long time, and now I'm in Florida. If someone comes in and says, I'm thinking about harm, well, that's an automatic stay, right?
Mm-hmm. Yeah.
So I kind of asked a whole bunch of things kind of there. Yeah. Just walk me through, one, if the ER is a safe place for people to go as a whole, or are they on the side of, I'm not even going to open this can of worms, right? Or will people even disclose? Have we traumatized them so much in the system that they can't tell us?
Yeah. No, it's a good question. And probably my broader answer or broader approach is, again, speaking to my fellow healthcare professionals, be very forgiving and kind to yourself. And one thing I say early on in my talk that you'll hear is that I'm going to talk a lot about the statistics of, such percentage of patients that ended up dying by suicide had presented to primary care, all these missed opportunities. None of this is meant to impugn any of my fellow providers. This is not a criticism. This is not you're doing something wrong. My education is really about what we all want to do is just improve our practice, right, and kind of get a little better about catching. I'm getting a little better about catching a pre-diabetic. I'm a little bit better about catching, someone whose blood pressure is getting into a bad place. I'm getting a little bit better about catching a potential thyroid issue, right? So we want to get better about catching these, but none of this is meant to be blame. So this is tough, and this is really tough. And this is potentially one of the toughest parts clinically of being a healthcare provider, especially being a non-psychiatric provider, because you're seeing the exact same human beings I see. I don't see different people than you see. I just have that toolkit and that structure to maybe handle these things better than during, because I spent many years in primary care in addition to the ER. We don't necessarily have that toolkit. So we're seeing the same patient. So be forgiving, be gentle of yourself. That's definitely primary. At the far end, at the extreme, yes, the ultimate decision is to place somebody under a legal hold, which happens just about every state. If somebody is at imminent risk of harming themselves or harming others due to mental illness, you place them in a legal hold. You take their rights away from them. Now, this is a huge deal. This is a huge deal. We, as healthcare providers, have police powers. And I don't know that I ever got talked to in those terms during my training, but we do and as nurses, we have, it's not something magical about being a psych MP. As nurses, medics, police officers, firefighters, just about every state, you can place somebody under a legal hold. You are taking away their individual liberties that are guaranteed under the Constitution of the United States. That's a huge thing. That's a big deal. And I think that's why most of us are nervous about it. Even if we don't think in those terms, we still think, geez, I'm the one that's going to pay, this person's going to be dragged out of my office. And we imagine this, it usually doesn't end up this way. But we imagine they're going to get dragged out of my office, screaming, cursing me, handcuffed. I place them, I got them thrown into an asylum because of my decision. So that's part of what makes us so nervous, especially at the primary care level. But at the extreme end, that's part of our licensure. We are professionals, we are licensed, we are granted a lot of abilities and powers by the state. In return for that licensure, we have certain responsibilities, and one of those is to help protect people from harming themselves due to psychiatric illness. That's the very end of the story. That's the extreme. Now, to answer your question directly, it is so easy for that to be a trigger. As soon as somebody says, I'm thinking about suicide, it's like, okay, hold. You're on a legal, whatever you call it. Every state has a different one. It's a legal 2000 in Nevada. It's 5250 in California. They all have their own terms, but basically I'm placing you under a legal hold to protect you from harming yourself. And it can be instant. And I want to bring a little space to that decision. Okay. Kind of like Viktor Frankl's famous quote that I will paraphrase, that in between, stimulus and response, we have that little area to make some decisions and do some thinking. And that's where I want to broaden it out and say, as a healthcare provider, there is an area between just not asking or ignoring if they say it, be like, I don't think you really mean it, which I don't think many healthcare providers actually do. Or the other extreme is the second somebody says they're talking about harming themselves, I'm going to put you in a legal hold. I'm going to lock you up. There's a middle part, and that middle part is talking, and it's asking details. This is the part. Again, so, okay, we're past that first part where, okay, I'm not afraid to ask. I've done all the training. I know I'm not going to cause suicide by asking about it. Every healthcare professional knows that. So I can ask. But the next barrier to get over as a healthcare provider is to be willing to ask questions. So now we're beyond, have you ever thought of harming yourself? Now we're at the part where you have to put up trigger warnings if you're talking in public, because that's when you're really saying, okay, have you thought about how you would do it? What, like literally, are we talking about X, Y, Z? Do you have means at home? Do you have weapons at home? Do you have firearms? Tell me about the knives you have in your kitchen. Have you ever attempted before? What was your means of attempt? What happened with that? Was it something, I took a bottle of ibuprofen and I woke up the next day with a stomach ache? Or was it, I did X, Y, Z and I ended up in the emergency room and I was in the hospital for a week? At that point, once you have that initial signal of a potential for thoughts of self-harm or suicide, that's when you take the time and you drill, because your ability to make an informed, comfortable decision is going to be maximized by having the most amount of details. And this is risk stratification. The person that has vague thoughts of not wanting to be alive, and then you get the chronicity. Is this a new thing? Okay. Or is this constant? Every day for the last 20 years, I've woke up thinking I don't want to be alive. I have many patients like this. I take them seriously. I'm not dismissing them. I'm not saying they're low risk, but I'm also not saying these are the same people that end up in hospitals every other week because they'll go say this to somebody and they'll get locked up. You have to assess. You do that risk assessment. And so those make very big differences.
I agree. And, the thoughts and the action of suicide are often symptomatology of something else. So we do a really good job in NP school talking about symptomatology and fleshing out details of a chronic cough or chest pain to do exactly what you're saying, right? What's the risk? Where do I go? Yeah. So All right. So we're going to trust our gut. Can you hear me okay? We might be having technical difficulties. Can you hear me?
Yes, try now. Is this better?
Yes, now I can
Oh,
hear you. That's perfect.
my apologies. Yes.
No problem. We are so real with all this, Rhone. This is great. So I was saying what we do in NP school is we teach risk stratification with symptomatology, and this, the thought of self-harm or suicide, or it would be great if I just didn't wake up. We do that with chest pain. We do that with cough, and I'm not sure, we really need to approach this in the same manner even in our own practice, right? Everybody with chest pain doesn't have an active MI that we need to send to cath lab. Okay.
Yeah.
All right. Trusting. Go ahead.
Yeah. No, you're exactly right. And that's we see that a lot in the emergency department, right? We see the patients that show up over and over and over again. Every time they have a little bit of pull in their chest, they get that full expensive cardiac workup, right? They get that whole huge thing. And you balance it. You're like, well, I don't ever want to miss a myocardial infarction. I don't ever want to miss a stroke. I don't want to ever dismiss somebody. And we never would. But there again, there's that space, a good risk assessment where maybe just a quick EKG, which is the equivalent of a good suicide screening, instead of doing a stress test, instead of getting them admitted. So yes, I like that analogy a lot.
In telehealth, in the world I work in, we do a lot of electronic forms, especially with our mental health patients, and it's primary care, but we do a lot of management of day-to-day of anxiety and depression, and we have a lot of success meeting people where they are. And we send a PQH9 and we send a GAD7. But we have, if anyone flags that they've had any kind of, then we have this other form that we have to send, the suicide form. And that's where I get patients backing up. They're like, wait, what is this? What do you think I'm going to do? That's where I have an issue. So how can we maybe, because we start out in text-based care and then we move to video. In those of us who are documenting and like handing out things, is it better just to ask some questions, or do we want this written down? Where do we get it?
Reasonable minds can differ on this. My bias is always towards just that interpersonal human contact. I think you can ask the exact same questions and asked verbally and asked human to human with some compassion and interest and care on your part is going to be exactly 100%, 180 degrees from just like exactly as you described those issues with written documents, right? We see this over and over again. And we see, the PHQ-9 is essentially the DSM-5 criteria for major depressive disorder. So I can have a patient fill out a form, and there's lots of uses for those sorts of forms. Or I can just ask those questions, have you had a sad or anhedonic mood? Has it been more than 2 weeks? And I can go through all those, sleep, interest, guilt, energy. I can ask all those questions, but I can ask them in terms of a conversation. And then I've done the PHQ-9, I've just done it verbally. The same questions that comprise the Columbia Suicide Scale or any of those can essentially be asked verbally because you're asking those questions I mentioned before. Have you ever, how often do you think of this? How would you do it? How strong do you feel you're likely to do this? You can ask those questions in terms of a conversation and get the exact same information. And then you can document it, and you can have a Columbia Suicide Scale up next to you while you're documenting, and accurately document, I discussed with this patient and they denied this, they affirmed this, they said it's this often. You can get the exact same information. Those documents are just human conversation put into a checklist form, which can have its uses, but for the heart of what we do as healthcare professionals, just the human-to-human contact is the heart of it.
I love that. I wonder if we should teach that and role play that a little bit more. We drill things like old cart into people's heads, and so people know onset, location, duration. But this sort of thing in a suicide risk, just being able to have that conversation very easily and to know those questions in your mind so that it comes off. I like that. I love verbally human to human. I get so much farther with a patient if I can just even call them or talk to them on the phone and they can hear me and hear the inflection, and it goes so much smoother. Trusting our gut. being willing to ask the question and then getting the details. Are there any, as we kind of wrap this up and talk about how we're going to get into depth in this in Vegas, are there any do nots that we should let providers know about? Like, here, this is something you probably shouldn't do with your patient who has.
Oh gosh, it's hard to say because I think anything I could think of, I don't think of any healthcare provider with any degree of competence doing, So it's kind of it's one of those things where anything I would say, I think anybody listening to me would say, well, I wouldn't do that anyway, so that's kind of foolish. But there's no there. So that tells us, first of all, there's no huge like red flags, like whatever you do, don't say this. Oh my gosh, that's the worst thing you can say. And we run into a lot of that in healthcare, and I just don't think it's fair. I think if you're coming from a place of sincere compassion for the human in front of you, they're going to read that just like we do. I mean, there's nothing different. Think of when somebody talks to you and they're compassionate and they're interested, it's very hard for them to say something that's going to hugely devastate you, right? Most of the time, we're going to take these things and say, okay, well, they didn't mean to misspeak. So if we approach it that way, I think it's very hard to do things wrong. If I had to pick one, I would say just don't minimize and don't kind of take anything I've said to say that like you don't have to lock them up, so that means you can minimize it. Take it very, very, very seriously because your interaction can be the interaction that keeps that human being alive, at least for the time being, right? So don't minimize it. Don't fall into the trap. Don't do leading questions in terms of, well, you don't really mean that, do you? This used to be my huge thing in triage because I'd work up in triage in the ER, like working with the nurses doing triage, and I would be there doing my assessments at the same time. And of course, as nurses, they'd be like, well, you're not like going through the checklist and say, okay, well, you're not thinking about hurting yourself, right? Or you don't hear voices, you don't see anything. You learn day one in psych is don't phrase it that way because it doesn't matter what the patient appears as, they certainly can. You just got to ask it. And if they laugh it off or chuckle, that's fine. If they make a joking response, that's fine. You can laugh right with them and just say, I asked this patient of everybody, because you know as well as I do, we never know what's going on inside of us, right? And the patient will say, yes. I said, so I asked this for everybody because it's my job to keep you safe and well. And most patients will understand that. So don't do leading questions. Don't minimize it. Don't not ask because you're nervous about the answer. At least asking and starting the conversation can only be a benefit to the patient. And other than that, I'd be hard pressed to say what not to do when doing this sort of assessment. And I'd be very interested in any audience feedback on that because I think there might be someone that says, hey, either because of my personal or professional experience, I found this was the wrong thing. And I always take that majorly into account. I don't consider myself an expert or at this subject. I consider myself very much a learner and a student.
I like that. The human compassion aspect of this has just been so prevalent to what you've said. And yes, if anyone who's listening or going to be in Vegas has some feedback on what doesn't work or what they found or what works really well, that's going to be a time we can really discuss what's happening. Okay, I appreciate that. I always learn the most from other clinicians, right? Oh, yeah.
Yep.
Parting thoughts or information for our audience where they can find more resources?
There is a group called the Suicide Prevention Research Council, the SPRC. I get a lot of good information from there, and that I pull on heavily in my talk because they produce some excellent open source, freely available, non-copyrighted information, not only about suicide assessment and prevention, but about training staff. So a lot of my talk goes into a lot more detail about how to train your office staff. So healthcare providers, non-healthcare providers, front of office, back of office, how to kind of approach this as a training opportunity with your staff. So I talk about that a lot more. So that would be my main source. And of course, SAMHSA has excellent resources. NAMI has excellent resources. So there's a lot of very good freely available. We have the 988 suicide hotline now. So it used to have to be 1-800-SUICIDE. Now across the nation, I think pretty much in every state, I believe it's nationwide, you can call 988 and get connected to those professionals at the suicide hotline. So that's something that I think any provider should know. Before it was 988, I used to tell my patients, I'd say, humor me. I know you're not going to need this for patients that hadn't queued, a significant issue. Just write down this number, please. Just keep it with you. Just know if you're ever in a place where you can't talk to me, you don't have a trusted person to talk to, and you're in crisis, you can call this line. Well, now it's just 988. Now I can just tell people, like, just like you do 911, you can do 988. So it makes it much easier. But that's a resource I think should be shared with every patient, especially anybody with depression, substance use, any of these significant comorbidities or risk factors.
Excellent. I wrote all of those down. The SPRC is great, so SAMHSA and NAMI, but we should be disseminating that 98 number more. So I appreciate the reminder, and I started doing that. Absolutely. Oh, Rhone, thank you for being here with us today, and for taking time to talk about this in depth. So we'll put this out, and anyone can listen to it. You can find us on YouTube. You can find us on Apple Podcast. You can find us on Spotify. But if anyone wants to hear your fantastic teaching live, you're going to be with us in Las Vegas in February, which is coming up in like 5 weeks, 6 weeks.
I know.
Time flies. I know. Welcome to 2025. And you also helped with the keynote in our great advanced psychiatric mental health pharmacology and precision medicine bundle, where you just did an excellent job on the call to psych mental health in this country, and it's definitely something that everyone should be thinking about. So we appreciate your work with that. Thank you for being here with us. To our audience, be sure to check us out at npace.org for all things NPACE and our Learning Center, where you could find the on-demand bundle we just talked about. NPACE is an ANCC accredited provider of continuing education, but we also, in Las Vegas, will be doing CME education with AAPA. So our PA siblings can join us there in an advanced practice provider forum. And we're going to talk about some difficult topics. So it's going to be a great conference. I encourage you guys to come and share any of your insights you have on the topic of suicide and suicide assessment with us there. Rhone, any parting thoughts before we sign off?
No, I think my number one parting thought to everybody listening to this is be sure to take care of yourself as well. We're taking care of others. Healthcare providers, we're under enormous stresses. We have suicide risk ourselves and mental health risk and all those things. Because again, we are human beings just like everybody else. We're not immune from this. So make sure you're taking care of yourself. Make sure you're taking care of your colleagues and your peers. We got to look out for each other. Our jobs are highly pressured, highly stressful, and we are seeing some big traumas come through, and that can be a bit traumatizing to us as well. So make sure you're taking care of yourself and your colleagues, and we all got to look out for each other, and that's how we look out for our patients.
I love that. Thank you for ending on that note. For everyone out there, take care. We'll talk to you next time. Bye.